Good morning. Good morning. I'm Sarah Bannon. I'm chair of the Abstract Work Group. And the volunteer reviewers, in case you didn't know, in the Abstract Work Group reviewed over 520 abstract submissions for this year's annual conference. And in case you didn't know, are blinded to the names and affiliations of all the submissions. So these abstracts you're about to hear are the highest scoring after 2 rounds of anonymous review, which is very impressive. You can use the attendance verification code 2450 to evaluate the session. And I am pleased to be able to present the recipient of this year's Best Member Abstract Award. The winning abstract was authored by Chenery Lowe and is titled Acceptability and Efficacy of an Online Communication Skills Training Intervention for Genetic Counseling. Congratulations to Chenery.
All right, thank you. I am so excited to be able to share some of my work. And first of all, thank you all for being here. You're much better people than I am to be here on the last day of the conference, or maybe you just really need the CEUs. But in any case, I'm going to head and share some of my work. And I want to say, first of all, this is really exciting to share as a lot of people in the NSGC community have been a part of this, including genetic counselors and genetic counseling students. So this is really, I think, a shared victory. And here are my disclosures. And I want to acknowledge my funders, which is the JEMF. So I want to start by reflecting on the theme of this conference, which is reflecting on purpose. And I see communication as being a vital part of our purpose as genetic counselors. So risk assessment, education, counseling, and decision-making all occur through communication and in the context of a therapeutic relationship. So it's important to ensure that all communication meets patients' needs. But there is some evidence that this is not always the case, and that patients from marginalized backgrounds may be at increased risk of experiencing communication that does not meet their needs. So specifically, genetic counselors may not discuss psychosocial issues to the extent that patients might prefer. And they also might dominate the conversation, leaving not enough room for patient voice. They may also overwhelm patients with the amount and complexity of information. And collectively, these suggest that genetic counselors are missing opportunities to serve those who could benefit the most from the communication, education, and counseling skills that we as genetic counselors have to offer. And we should focus on using evidence-backed communication strategies that promote patient engagement in the session, including both cognitively and emotionally focused discussion, and that emphasize easy to understand, concrete, and actionable information. So training programs should be able to help genetic counselors to establish patient-centered communication skills from the very beginning. But there's currently a limited evidence base about how genetic counseling students communicate and little research about the effectiveness of specific teaching approaches. However, based on a review of studies in other clinical professions and the current challenges and needs of genetic counseling training programs, it seems reasonable that an approach that is resource efficient, designed with principles of adult and active learning, aligned with practice-based competencies, and highly acceptable to learners may be the most effective and implementable ways to do this. So after identifying the gaps, needs, and opportunities, my co-authors and I set out to design an intervention that met these criteria And we selected the LEAPS framework for effective communication due to its alignment with the practice-based competencies, its applicability to multiple practice settings, focus on behavior change, and the fact that the skills largely aligned with recommendations to better serve patients with limited health literacy and those with significant psychosocial or decisional needs. So the intervention that we designed was a series of online training modules to help students to begin to use and practice skills in a low-stakes setting. It included 3 to 6 skills per module, 5 modules, about 30 to 45 minutes long each. The content emphasized basic communication micro skills that could be widely applied across settings. And it was online, asynchronous, and self-administered that would start with a skill definition, several video examples of a genetic counselor demonstrating those skills, opportunity to practice skills by responding to a recorded video prompt, self-assessment questions, and then students had the opportunity to either do additional practice or they can move on to the next skill. And the online training modules were designed to be self-administered to reduce the potential burden on preceptors or supervisors and to allow students to experiment and practice without external pressure. So in this study, we recruited 60 genetic counseling students and recent graduates who had not yet taken a certification exam to participate in a crossover trial that evaluated the modules, and participants who completed a baseline standardized patient session involving return of results in the cancer or prenatal setting. And they were randomized to receive access to the modules either immediately, which I'll call the immediate group, or after completing a second standardized patient session, which I'll call the delayed group. And the sessions were analyzed using the Rotor Interaction Analysis System, a widely used communication analysis system. And to assess efficacy, we compared student performance during the second SP session when one group had completed the intervention, but the other had not yet completed it. So moving to results, during the second standardized patient session, we found that the immediate group had more frequent use of emotionally responsive statements and teach back. There were also trends toward more frequent use of the listen skills, which were focused on eliciting the patient perspective, and a higher patient-centeredness ratio. And just a note about teach back, this is essentially a skill in which the clinician asks the patient to summarize what they heard or understood, and it's an important skill for getting on the same page, addressing misconceptions, and has been linked to increased adherence, knowledge, self-efficacy, and improved patient outcomes. And it may be especially beneficial for patients with low health literacy. So we were excited to see the increase shown in yellow on the graph on the right. And there were several outcomes that we did not find any differences by group, which I go into in the publication. You can read that. So we found that students who completed the study found the intervention to be highly acceptable. Students generally enjoyed the modules, that they would recommend them to other students, found them relevant to clinical practice, and a majority would also recommend using the modules as a part of their own program's curriculum. We also asked, we wondered if the training influenced their behavior during actual clinical cases, which could differ from the standardized patient cases that we saw in the study. And this gives us some idea about the persistence of the intervention effects, as well as the transferability to a more realistic clinical setting. And we did find that most students said it was either extremely or slightly easy, although there were a sizable number who at least found some challenges to using them in practice. So we wanted to go into this a little bit more and ask students about what were some barriers that they saw to using the skills in clinical practice. And a majority reported that focusing on using different skills was a barrier, with sizable numbers also commenting on other barriers, such as not having enough time during the session, the supervisor's preference to focus on other skills, being too nervous to use the skills, not being confident to use the skills. We also asked about what facilitated use of these skills during actual sessions, and some that were rated highly included perceived relevance to the session, having enough time during the session, and perceived support from program and supervisors. And notably, these were endorsed more frequently than even personal confidence in using the skills, which suggests that perceived alignment between the skills, patient needs, supervisor, and program support may help students to feel like they can and should use and practice these skills. A few exploratory findings. We wanted to know whether this might be better suited for students who are earlier on versus later on in their training. And we found that compared to first-year students, second years, and recent graduates were more likely to report as a barrier that there was not enough time during the session to use the skills. They were more likely to report as facilitators that their clinical supervisor and training program supported the use of the skills. And this may, although it's quite preliminary, suggest that these skills might be better incorporated earlier on in training when students have the opportunity to sort of practice these without having to consider all of the many things that they're trying to incorporate in addition to patient-centered communication skills. We also wondered, so students had the opportunity to verbally practice the skills, and some reported that they did, and some reported that they did not. And we found that among the students who did verbally practice the skills, they were less likely to report being too nervous to use the skills as a barrier to skill use in actual practice. So this could suggest that verbal practice may aid in skill transfer, but we can't really define a causal relationship. It's possible that there may be underlying nervousness that both prevents students from verbally practicing even by themselves and also using them in practice. So this needs additional study, but is an interesting finding. Some limitations are one that this may overrepresent students who are more interested in developing their communication skills. And it's also a simulation-based study, which may differ from actual practice. There was some loss to follow-up with only about 58% of students completing the study. But this does suggest that formal incorporation of the intervention into a training program might be necessary to improve for it to be maximally useful to students. And we did also note that there didn't seem to be significant differences in non-completion based on which arm the students were randomized to. So next steps for this research include, can we identify ways to improve or expand the modules? How can they complement an existing training or practice strategies? At what time in training is this most valuable? How can we encourage skill transfer into the clinic? And how can we sustain patient-centered communication practice over time and even beyond graduation? One thing that I'll note, sort of a real-world update, is that the BayPath genetic counseling training program did use these modules last year, and they plan to use them again this year. And then I also want to acknowledge the many people who were involved in this study and this project. First of all is Deborah Roeder, who is my dissertation and primary advisor on this, as well as my JEMF mentors, Lori Irby, Barb Biesecker, and Galen Joseph. The 4 standardized patients who spent quite a lot of time on this, and also hopefully a lot of people in this room or online who helped to train the standardized patients, reviewed the simulation scenarios, and also who participated as module actors, actually demonstrating the skills. I also want to say a huge thank you to the JEMF advisory group, and the JMF and NSGC for providing funding and support for this, as well as the genetic counseling program directors, fieldwork coordinators, MGPN, state and regional genetics networks, and others who help to recruit. And the study participants, many of whom are out there practicing genetic counselors now. And also, if you are interested, the LEAPS modules are freely accessible and available to the public. You can scan the QR code shown on the slide, or use this link to access them. And I really encourage you to reach out to me if you're interested in collaborating on research or have any interest in this. And there are several publications on the data that I presented today, as well as a few forthcoming. References, thank you so much.
Okay, thank you, Chenery. It is also my honor to present the recipient of this year's Beth Fine Kaplan Best Student Abstract Award. This year's award goes to Yusra Aziz for her abstract titled The Need for Racial and Ethnic Health Disparity Curriculum in Genetic Counseling Programs. Congratulations, Yusra.
Hello, everyone. Thank you so much, Sarah and NSGC, for the honor of being of this award. So let's go ahead and get started. So I will be presenting my thesis titled The Need for Racial and Ethnic Health Disparity Curriculum in Genetic Counseling Programs. So before I get started and going into more detail about this, I think it's really important that we view this research through the lens of health disparities and public health. We know that race and ethnicity is a social determinant of health, and especially in the US healthcare system, racially and ethnically minoritized individuals experience health disparities due to systemic racism. I'll be abbreviating racial and ethnic health disparities as REHD, and REM will be used to abbreviate racial and ethnic minoritized groups. I do want to pause here and say, talking about race, talking about racism, and talking about health disparities are very real experiences. They're real experiences for me, and they're real experiences for many of you all that are sitting here in this crowd. So I want to acknowledge that some of these subjects that we talk about might be difficult to hear, and if they challenge your worldview, really sit in those feelings and question why you're feeling the way that you are. Let's understand kind of what the field of genetic counseling has done to address these topics. So there's been an overall increase in research relating to JEDI in the field. However, there's been an overall lack of standardization about JEDI practices, specifically in graduate training. There's been a lack of addressing systemic racism, healthcare inequity, and explaining historic discrimination in our field. And recent research has shown that both genetic counselors and students have variable comfort levels in addressing the topics of race and racism with their students and their patients. There has been the use of conscripted curriculum to traditionally teach about these subjects. So what is that? It's when REM students educate their more privileged peers. So for example, we're sitting in a classroom, I'll use myself as an example, and we want to talk about, say, Islamophobia. And someone asks me to use an example of maybe a racist experience that I had in the past couple of weeks. What that does is that incorrectly positions the discussion of the topics of disparities on an individual, instead of addressing the systemic reasons about why these disparities exist. And honestly, it puts an unfair burden of education and emotional labor on these students. I don't want to relive those experiences, and I don't want to have to educate my peers as a student. Now I want to stand here and really talk about my why. I think it's a really important thing to do, especially when talking about such personal and such real experiences. So in order to really combat disparities and these problems that we face, we need to know why they exist in the first place. It had always bothered me how race and ethnicity was discussed as part of my education growing up here. And so this research is really for my friends and my fellow people of color who've always wanted the greater answer for why we face these inequities, but are never taught about why. So there's recently Berger and Miller posed a really good argument about shifting from the lens of cultural competency and humility to the use of instead teaching US social and political history and structural and systemic racism. So whenever we approach teaching these subjects through cultural competency and humility, it's really an ethnocentric lens that we're using, and we're othering other cultures by doing that. So we really want to start focusing on teaching through the lens of structural and systemic inequalities and giving a good historical background about why these things exist. So for example, Harry H. Laughlin was part of the Eugenics Records Office. And in the 1920s, he was called to the US Congress to come testify as related to anti-immigration laws. And he talked about how, and I'm gonna read the quote on the screen. He talked about, in our immigration law and practice, deportation is the last line of defense against contamination of American family stocks by alien hereditary degeneracy. The first line of defense is the attempt to exclude certain types and classes of antisocial and otherwise undesirable persons from admission into the United States. So these eugenic ideals went to inform the 1924 anti-immigration laws and put a quota on immigrants that came from East Asia, East Europe, and South Asia abilities to come to the US. So it's examples like these that are really important to teach in the curriculum that give us a lens of the downstream effect of these disparities that we experience today. So we know that the ACGC has instructional content areas, and when this study occurred, we used the 2019 ACGC instructional content areas, and I do want to acknowledge that new ones have recently been published, but there are areas in these content areas that have room for improvement and also address racial and ethnic health disparities. So we noted that overall, REHD and genetic counseling program curricula has not been studied. So our research question was, what topics related to REHD should be taught in genetic counseling programs? And we wanted to do this by identifying what topics genetic counselors had exposure to in their training, what topics they've encountered during their practice, and what topics they find important. We also wanted to understand how counselors describe these topics related to REHD. We had a total of 182 genetic counseling participants. We distributed the survey online through Qualtrics, and we did this by the multi-pronged snowball recruitment method. And then we used a quantitative analysis and also thematic coding. Our survey was designed and split up into 4 parts. The first part covered definitions and foundational topics related to REHD, then genetic counseling, genomic, and genomics topics, and also historical and political topics related to marginalized groups. And then we ended with open response. So let's get into the results and discussions. So we overall had 74% white genetic counselor participants, and then we had a spread of 26% REM participants. So these next couple of graphs I'm going to go over are going to talk about when people were exposed to certain topics. At the top left, you'll see the setting in which these participants were exposed. So here, for example, we have what topics participants were exposed to during their lived experiences. And on the x-axis, you can see the certain different types of topics, such as privilege, health disparities, cultural humility, just to name a few. So we can see that 88% of participants learned about privilege during their lived experiences. We also see here that participants learned about all of these topics except for privilege. More than 50% of participants learned about these topics during graduate training curriculum. Cultural competency, 87% of participants learned about this topic, and 78% of participants learned about health disparities during their training. Now, when we look about what topics participants were exposed to during their NSGC, we see there was overall a lower amount of exposure. And you can really see that stark difference when we compare it to what they were learning in graduate training curriculum, which poses the question about what do we need to do to eliminate this difference. I had a participant say that I do want to note that I learned about all of these topics in my ethics master's degree, but not my genetic counseling degree. Another participant also highlighted that learning the context and bigger picture of how that happened and still affects individuals today is important. So we then wanted to learn who was learning what and when. So the image on the left is all the variables we ran in a regression model, and those that are highlighted in this figure in purple were significant. So we learned that REM counselors are more likely to learn about these topics through their lived experiences compared to their white peers. So for example, 5.25 times more likely to learn about implicit bias through their lived experiences. We also learned that those who graduated before 2015 were less likely to learn about these topics. So 47% less likely to learn about health inequities. We also learned that graduates who graduated before 2015 were less likely to learn about genetics and genomics topics. So 56% less likely to learn about health cancer screening disparities between racial and ethnic populations. Also, 55% less likely to learn about anti-immigration laws. We then had participants rank what topics they found important to include in graduate training curriculum. So we included the topics that more than 25% of participants included as important. We then went and asked respondents what topics they thought were important, just as an open response, and we identified a couple of different themes, such as participants wanted education about disparities in access, education about foundational topics, education about how to combat disparities, expert educators' opinions, and the history of disparities. One participant said, GC programs need more history. Not everyone is coming into school with the same lived experiences. I then wanted to further highlight the topics that our REM respondents included. So these highlighted are the themes that were further expanded upon by our REM participants. So standardized curriculum, self-reflection, and further historical context of medical racism. This participant said, I would like to see more historical background to understand disadvantaged populations. So for our conclusions, we know that REHD topics are important not only to include in graduate training curriculum, but also in continuing education. Graduates that graduated before 2015 were less likely to learn about these topics in training, but actually more likely to learn about these topics during their practice, which calls for more education about this, and these are things that really affect our practice. So this concludes with an overall inclusion and expansion of REHD topics and genetic counseling curriculum. Furthermore, there was an overall call for experts to teach our experts in REHD and REM individuals to teach these topics. Racial and ethnically minoritized counselors are more likely to learn about these foundational topics compared to their white peers. So this calls for a need for all, but especially our white genetic counselors and our more privileged genetic counselors to really consider and reflect their racial identity and its interplay in our systems of oppression. So we suggest that graduate training curriculum includes topics that span across definition and foundational topics, genetic counseling, genetic testing, and genomic topics, and historical and political topics, especially as relating to marginalized groups. There has been an overwhelming desire for actionable change. Given the particularly unique history of the field of genetics and genetic counseling in further exacerbating racial and ethnic health disparities, it's imperative that genetic counseling programs take that responsibility to further educate. This study serves as a call for leaders in the field of genetic counseling, such as ACGC, the National Society of Genetic Counselors, and AGCPD, which I know the name has changed since then, to collaborate with experts in REHD curriculum, to collaborate with racially and ethnically minoritized individuals to create a health disparity curriculum. And I want to end here by saying there's no easy fix to systemic racism. There's no easy fix to these disparities that we all face, but I really want to urge all of you all that are sitting here in the crowd to really do that self-reflective work about your identities and how they interplay in the systems that we partake in. So thank you all. I want to give an acknowledgement to my thesis committee, specifically Claire, who's sitting here out in the crowd. Thank you to MD Anderson UT Health Graduate School, and a specific thank you to all of my survey participants who took this survey and were extremely vulnerable in the open responses. I urge all of y'all, if any of you are interested in further conversation about any of the feelings you are feeling during this presentation, please come up to me and we can have a further conversation about it. Thank you. These are my references, and thank you so much.